What are you watching in healthcare? What are you spending your mental energy on? What is commanding your attention these days?
Well, the first and the largest at the moment has been and remains the integration of behavioral health and physical health through IMC with the Medicaid population. This a few weeks ago, January, we went live with the final 3 regions and the final counties. So Molina now covers all counties, all regions across the state. But to the comments earlier, this is just implementation of integrated funding. Now the real work for us begins, which is supporting and enabling the true change in the healthcare culture to integrate mind and body.
One of the most consequential things, I think, of the Affordable Care Act that we probably did not see coming was how Medicaid plans had to fundamentally transform from plans that covered mostly women and children to plans that had this whole new population, maybe 40 to 60% of the population of childless adults, many with very complex chronic conditions. How have you seen Molina specifically, but Medicaid, sort of learn because of this new population and become a different kind of plan, a different kind of Medicaid plan?
It's a great question. We are every day now, and Dr. Green's presentation just now brought it home once again, aware that we are in focusing only on traditional healthcare delivery, that we are only touching maybe 10 or 15% of health. And for us, it has been a shift from healthcare to health, in realizing that we weren't equipped to deal with health because we are part of a system that for so many decades was focused on a very specific population set with a very narrow set of defined health care needs. So now more and more we are thinking about what are the social determinants and realizing that we need community to do that. We can't do this alone, and that we've got to find partners throughout the state but within each community to really begin focusing on the social determinants piece and not just the healthcare.
So some of those social determinants changes can occur in state law and with amendments to our state Medicaid plan. Some of them require a waiver of select federal rules about what can be paid for and what cannot be. We're at the beginning of year 4 of our 5-year 1115 Medicaid waiver. When that gets renegotiated or when our next waiver is negotiated, what are the kinds of things that we ought to be thinking about in terms of social determinants, in terms of taking what we've learned so far in this waiver and applying them to the next?
It's another great question.
Good thing we're friends.
It is a good thing. We think that the United States and this state is spending the right amount of money, but we're spending it in the wrong places. So that's been quoted often with a number of speakers today, again, reminding us that when we compare U.S. spend on health care and compare it to other first world countries, that we spend a lot more and our outcomes are a lot worse. But if the data now look at it and they say, look at what countries are spending on the combination of social determinants of health, housing, education, sustainable wages, food security, transportation, plus traditional health care, we are spending in this country about the same amount of money as the other countries. Their outcomes are a lot different, so the spend is actually about the same. What's different are the outcomes because they're spending a lot more of that spend on the social determinants and the social fabric of health, putting roofs over people's homes, food security, et cetera, and not focusing so heavily on traditional healthcare. That's, I believe, is the big shift that's to come for us.
So prior to leading Molina, which I think is the largest health plan now in terms of fully covered lives in Washington State, you've got an individual market presence, you've got a Medicare market presence, but the biggest part of your lives are obviously Medicaid. But you used to be at Peace Health, large multi-state provider. And you were at Group Health before that, and you've been at other provider organizations. So what do you make of this public option legislation and the idea that, at least so far in the individual market, that it is appropriate policy to cap provider rates as a tool, essentially to keep costs down? Is that the direction policymaking should be moving and expand so that it doesn't maybe distort other parts of the system with cost shift, or is it just too early to tell?
Can I have another question? I think that the public option, Cascade Care, we need it. Molina supports it. We're all in to be successful, to help it be successful. We believe that because we still have 5 to 6% of the people who live in every one of our communities that aren't yet insured. Those people and the costs, I mean, they're not all homeless, obviously, or people experiencing homelessness, but the costs of the uninsured are significantly more over time than the costs of the insured. If Cascade Care can in fact help us in this state cover the remainder of this population that isn't insured, it will allow us, I believe, then to go to our commercial environment and our providers and lower the rates of what's being paid and what's being charged, because that's where the cross-subsidy is. So I'm much more supportive of getting everybody insured and providers compensated at a reasonable level than where we are today, where we are overcharging by necessity and cross-subsidizing the uninsured and the underfunded Medicaid through inflated commercial costs. Mm-hmm. If commercial healthcare costs were to come down and equalize as a result, our employers would be able to deliver much more sustainable wages. They would have money, we would be much more competitive on a global market in terms of the cost of our labor and our services. It would be better for the economy, and we wouldn't need then to have artificial caps and floors.
Mm-hmm. We could do this for a long time. Good. It was a quick 8.5 minutes. Peter Adler, President of Molina Healthcare of Washington. Sir, thank you very much.